Welcome to the Indian Health Service COVID-19 Clinical Readiness and Patient Care Teleeducation Project ECHO session for July 16th, 2020. My name is Sean D'Andrea. I'm the Chief Clinical Consultant for Emergency Medicine for the Indian Health Service. Today, we'll be joined by Dr. John Irulu from Gallup Indian Medical Center, the Chief Clinical Consultant for Infectious Disease, to provide a clinical update regarding COVID-19. Then we'll move into a discussion, which is a bit of a change in pace for, or not pace rather, but content for these sessions, because we're going to start to talk about influenza vaccination coverage for the areas that we serve, and then considerations for influenza vaccination in the age of COVID, which will certainly be a quite nuanced and rich discussion today. We're joined for that by Dr. Tom Weiser and Dr. Tara Jathlui. If there's time at the end, as always, we'd like to have a Q&A session. However, there's a fair bit of content this week. So as always, we're going to remind folks to please submit questions through the Q&A feature of Zoom, which is located at the bottom of your screen. And our speakers will do their best to answer questions in real time. Please don't forget to complete the post-session survey for CME credit. This will be pasted into the chat feature of Zoom on the right side of your screen. And a couple of quick reminders: the session is recorded and your attendance serves as consent to be recorded. The recordings will be made available for distribution following the session. Please see the initial email announcement from Project ECHO for the speakers' slides today. And again, CME is available following completion of the post-session evaluation. And with that, we'll get right into the clinical content, and I'll turn things over to Dr. John Irulu at GIMC. Thanks, Dr. Irulu.
Hi, good afternoon, everybody. I'm going to give you a brief clinical update, basically a potpourri of some interesting papers that have come out in the last week. So first is one on comorbidities in HIV. And this is a look by Amo et al. From the Annals of Internal Medicine, roughly a little over 2 weeks ago, on the incidence and severity of COVID in HIV-positive persons who are on antiretroviral therapy. So it's European. There are 77,000 people on ART, antiretroviral therapy. And of these thousands of people, 236 developed COVID-19. Roughly 151 were hospitalized, 10% were admitted to the ICU, and 20 died in this group. And they found that among these HIV-positive persons, men and persons who were over 70 had the more frequent diagnosis and more risk for hospitalization. And what was kind of interesting is they found out that the antiretroviral drug somehow influenced the diagnosis rate, hospitalization, and perhaps even the death rate. So there's an old drug called tenofovir disoproxil fumarate, also known as TDF, an older formulation of the tenofovir drug, which we've largely abandoned in favor of a drug called tenofovir alafenamide. I won't give you the brand names, but it's the old blue pill versus the new one. And if you look at people who are on the old blue pill, TDF, they had a smaller diagnosis rate per 10,000. In this population, the hospitalization rates were about 50% less at 10.5 versus 20.3 per 10K, and not a single person in the TDF group was admitted to the intensive care unit or died. So this is tantalizing data. None of us use this. We do use this drug as part of a pre-exposure prophylaxis regimen to prevent HIV infection in those who are HIV negative. But makes me wonder if maybe for the next year or two, I should switch all my patients back to the old-fashioned drug. Just kidding. Next slide, please. Good. So how about the effect of COVID on maternal, perinatal, and neonatal outcomes? And this was by Juan et al. In the Ultrasound Obstetrics Gynecology Journal in July. So basically, I'm going to be presenting to you two papers that aren't very strong, but they're kind of interesting. The first is a review of 24 studies, including 9 case series and 15 separate case reports, with a sum total of 324 pregnant women with COVID. The maternal age was age 20 to 44. Gestational age was from 5 weeks up to 41. And just like with regular COVID and everyone else, fever, cough, dyspnea, myalgia, and fatigue are the most common symptoms. Only a small percentage had severe pneumonia at 0 to 14%, kind of like regular COVID, and all required intensive care. 219 delivered, 78 by C-section, nice high APGAR scores. In this part, they noted that only one neonate died of asphyxia in the case reports that they reviewed, and they didn't know of any maternal deaths in the case series, which were consecutive, but they did have 9 deaths in the non-consecutive. So that's 9 deaths out of 324 pregnant women total. Next slide, please. So how about some CDC data? There's a report by Ellington et al. Showing hospitalization rates that were higher at 31.5% in the pregnant women compared with non-pregnant. And the risk for hospitalization was therefore 5.4 times higher in pregnant women. Risk of ICU admission higher 1.5 times, and risk of mechanical ventilation 1.7 times higher. This CDC group showed no difference in the risk for death among these pregnant women. ACOG reviewed this and basically dismissed the study. They were concerned that the pregnancy status and the people who were who were hospitalized with COVID pregnancy status was missing in 72% of the women, and the underlying conditions were not reported in 77%. So they kind of downplayed this paper. And next slide, please. And why do I bring up ACOG? ACOG put out some guidance on what to do about pregnant healthcare workers. Can they work in COVID care, or should they avoid it? And so they actually put out a position statement that you can find that was put out roughly last Tuesday. I apologize for not having the reference, but if you Google ACOG pregnant healthcare worker, you'll find this immediately. All of the 4 statements were made that are important. Should pregnant healthcare personnel do non-COVID care? First, it says it's absolutely mandatory that healthcare providers, whether pregnant or not, should be prescribed proper PPE and follow the healthcare guidance put out by CDC. So that's like their first statement, very important to follow standard operating procedure. They do state that healthcare facilities may consider limiting exposure of pregnant healthcare personnel to COVID-19. And they say that you should definitely do that if you don't have adequate PPE. If you don't have the N95s for aerosol generating procedures, you don't have the proper gowns, gloves, and face shields and goggles, and you have a pregnant healthcare provider, they really should not do COVID care. But they do state that pregnant individuals may work in patient-facing roles, so face-to-face care, until they give birth if they so desire, and all recommended PPE are available. So they're introducing the concept of the provider wanting to do this kind of care or not. So this is the ACOG guidance. We don't have national guidance in the Indian Health Service. You do have to be concerned about federal regulations in human resources about accommodations. So urge you to think about this on your various area levels. I mean, maybe you will eventually have to address this nationally as an agency. Next slide, please. So next, persistent symptoms. We like to think of COVID as something that hits somebody and 10 days later they feel great and they want to go racing back to work. Here's a paper by Carfi et al. Published in JAMA on July 9th. And it comes from 143 patients from Rome, Italy. This study by this group at a place with an amazing name, Fondazione Policlinico Universitario Agostino Gemelli, IRCCS, for post-COVID care. So they had a lot of people, 143. The median age was 56. 37% were women. You can see the age range there. A lot of the patients had interstitial pneumonia. Length of stay was 13.5 days, 5% intubated. Only 12.4% were symptom-free. And you can see that fatigue dyspnea, joint pain, and chest pain went out as far as 60 days. So this is not an illness that goes away fast. Next slide, please. Then persons who died, this is a United States MMWR report, and there were 52,000 deaths that occurred between February 12 and May 18. Half of them were male, 80% were greater than 65, and the median age was 78. And what they found in a second supplemental surveillance study of 10,000 deaths were 34% were Hispanic, 29% were non-white, and in the group that were less than 65 years of age, these rates are double that for whites. So they're concerned about these two minority populations in this study. And underlying conditions were present in 3/4 of those persons who died. And you can see the chronic lung, chronic kidney diabetes, and cardiovascular disease. Next slide, please. And so in COVID land, we sometimes have the news comes out in the New York Times first before it appears in the medical press. So this is a paper from the New York Times, an article from the New York Times entitled 68% of antibodies in this clinic. Can a neighborhood be the next wave? It's by Goldstein, published July 9th. And they report on a clinic in Queens, New York, 68% in the Corona neighborhood. So ironically named Corona neighborhood had antibodies to COVID-19. In Jackson Heights, 56. In a wealthier neighborhood in Brooklyn called Cobble Hill, only 13% had antibodies. So the one question, none of us know for certain whether having a positive antibody test means that you're safe. But the question that you might have is, has this community achieved that kind of goal of herd immunity? And these two neighborhoods have very large minority populations. So the question would be, will this heavily affected minority communities have lower incidence in the future? Will there be a second wave for that community? So nobody knows the answer to that question, but it's a kind of an interesting idea. Here in the Southwest, we've had very high incidence of COVID, and we really hope that there will be protection for the population, but we haven't done a serosurvey yet. We're in the process. Next slide. And then in the same antibody arena, the SARS-CoV-2 mRNA vaccine update from the company Moderna that we talked about roughly a month or a month and a half ago. They finally published their preliminary data in the New England Journal of Medicine. It's a phase 1 study, so they're basically looking at early on the safety of this 1273 vaccine. So it's basically a piece of RNA that's been modified, and it has a lipid nanoparticle encapsulating it. So it's kind of like contained inside. They gave it to just a small number of healthy volunteers at 3 different doses, both at day 0 and day 28. And they didn't find any very serious adverse effects. I think they had 3 people who developed some hives. And they noted that a very common complaints were fatigue, chills, headache, myalgia, and pain at the injection site. So it sounds comparable to influenza vaccine. They were able to ascertain that these patients had really robust immune responses that were in the range of someone who is convalesced from an infection with COVID-19. So encouraging that there was a good antibody response. And they had the study was not shut down for safety concerns. So they have a phase 2 study that's ongoing, and they apparently will be enrolling people in a phase 3 study later this summer. So kind of an exciting, enticing concept of a vaccine. And the accompanying journal in the New England, accompanying editorial in the New England Journal kind of had a bar graph showing that like a timeline showing that usually this takes about 3 years to get from point A to point B, which is a vaccine that's widely available. And they wrote in the text, talk about doing this in as quickly as 6 months. So kind of exciting data. Next slide, please. Great, and these are some of the guidance we encourage you to use. Next slide. And this is a picture from Zuko Valley near my family's home in Nagaland. And you can see that there's a little break in the clouds up there on the right, and I'm hoping that's what's going to happen in COVID land. That's it. Thank you.
Thank you, as always, Dr. Irilu, for that excellent update this week. And now we're going to turn things over to Captain Tom Weiser to talk this week about updates for IHS influenza vaccination coverage. So something that we can't be forgetting about rather in the age of COVID, but we're going to have to remember to consider influenza, which is certainly still out there. Captain Weiser is the medical epidemiologist for the Portland Area Indian Health Service, assigned to the Northwest Portland Area Indian Health Board and Northwest Tribal Epidemiology Center. He's been with the Public Health Service since 1998, initially serving as an IHS medical officer in White River, Arizona from 1998 to 2005. Dr. Weiser completed the CDC Epidemic Intelligence Service from 2005 to 2007. In addition to supporting general public health and epidemiologic research at the Northwest Tribal Epidemiology Center, Dr. Weiser is also the co-chair of the Portland Area IHS IRB and is the Area Immunization Coordinator. Nationally, Dr. Weiser serves as on the IHS Heroin, Opioids, and Pain Efforts, or HOPE Committee, as the chair of the Metrics Subcommittee, and since 2018 has served as the IHS ex officio representative to the CDC Advisory Committee on Immunization Practices. So Dr. Weiser, with all that you have going on, we're very grateful for your time today. Thanks for joining us.
Thank you, and greetings from Warm Springs, Oregon, where I've been coming out to yesterday and the next couple of days just to kind of take a look at the situation on the ground here and see where there's some opportunities for improvement. And it's lovely out here. Last year I was here to see or 2 years ago to see the eclipse, and last night I got to see a little bit of the comet. So it's nice to be in a place where there's not much light pollution. Anyway, if we can go to the next slide. So I'm going to talk a little bit about the Influenza-like Illness Awareness System, or IIAS. Some of you may be familiar with this, some of you may not be so familiar with it. This was developed by IHS kind of on the fly during the H1N1 pandemic, and it's been enhanced ever since, and we continue to use it. And this data is developed every night. Those sites that use RPMS, while we're sleeping in our beds, it runs a report, and it sends that report to Albuquerque, where Larry Lane and others compile those reports into weekly reports that we get to see. And what it does is it looks at all the visits to the clinic during that day, and then it looks at the number of those visits that was due to influenza-like illness as defined by a set of ICD codes and whether or not someone had fever. And so this is very similar. It's based on the CDC's ILI surveillance that you can see on the flu view every week during flu season. And we've been looking at this, especially now with coronavirus, looking to see if there are any changes in these kinds of indicators that we might say, oh, that's where coronavirus was, or did we miss coronavirus early on, perhaps? And so the graph I'm showing right now compares two flu seasons, 2018-19 and 2019-20. So the green line, or what's mostly the lower line on the graph, is the 2018-19 flu season. And it was a pretty typical season. I think we had both H3N2 and H1N1 circulating that year, with a bit of a mismatch in the H3N2 component of the vaccine. So there's like a little spike early on and then another spike later. For last year, we had that unusual flu season where we had influenza B circulating first, and then followed by a lot of H1N1. And so we had a double spike last year too, but those spikes were much higher. So we got up to 9%, almost 9% in our percent of visits that were due to influenza-like illness at the peak. And that was early on before the beginning of 2020. And then it came down, and then we had a broader transmission season this year, so it lasted a few weeks longer than it did in the previous year. And you can't really tell from the graph looking at it where, there was a big impact from COVID. There's maybe a little bump out there in week 12 or so that maybe is related to COVID, but we still had a lot of flu that was circulating. I know we were getting a lot of flu tests in our area during that time. Next slide. And this graph shows you the number of doses, or the percent rather, of the patient population that was vaccinated. And that's the percent of the population that's actually being reported on by this system. And I'll have another slide later on that shows you how reporting has actually declined over the last few years in this system. But this is pretty typical. Almost every flu year, we see this same pattern of a steep uptick in influenza vaccination starting around week 37 or 38. And it lasts for about 4 to 6 weeks, and then it tapers off. And then by the time we get towards the end of the year, it's almost a flat line. And then often we see right after the Christmas holidays, there's a little bump up primarily in children getting vaccinated, because after the holidays, they come back to school, and then there's maybe a little bit more flu being seen in the communities, and people come back in and get their flu shots because others are saying they had the flu, or there's a lot of kids getting sick at school and that kind of thing. So we typically see this bump up, and the blue line is the children 6 months to 17 years. And we see that increase in flu vaccination activity following the beginning of the year. And then there's very little flu vaccination in the later part of the season in January, February, or March. And then after March, it's a flat line. And so this hasn't really changed. This pattern overall hasn't really changed much at all over the previous few years. Next slide. So this is a clustered bar graph that shows you the vaccination rate overall for the different areas. And then the first cluster is the national overall vaccination rates. And so you can see in some of these areas that look low, it's probably more related to a lack of data than it is to a lack of vaccination. And you see that our vaccination rates for seniors in most areas are highest. So the 65 and older age group usually has the highest rate of vaccination. There are a couple of exceptions to that. Tucson actually has higher vaccination rates in their children 6 months to 17 years. And then some of our other areas also have pretty high vaccination rates for children. Navajo has really high vaccination rate for children as well. And, we often talk about children being vectors of disease, and whether or not it makes more sense to try and focus our efforts on vaccinating children to prevent the spread of disease rather than focusing all of our efforts on vaccinating older individuals who have less of a response to the vaccine sometimes. And we might be able to get more bang for our buck. Certainly we've seen that with pneumococcal vaccination over the years, which led to the ACIP's change in their recommendation on the PCV7 recommendations for older adults. But this just shows you some of the variability there in the different age groups and by area. And you can take a look at your area and see where you're at. Next slide. So I think this is really important when we look at this data system to keep in mind that it's not complete data. It's not all the data. It's not all the vaccines that were given. It doesn't represent all the populations. RPMS. The bulk of the tribal sites in our area don't use RPMS, and so they're not reporting into this system. So it's reasonable to use for surveillance, but we should keep in mind that it's really a sample. It's not complete. And then on top of that, you can see the number of, in the black line, the black dotted line shows you the decrease in the number of facilities reporting. So using the right vertical axis, it's gone from about 350 facilities reporting to around 200 facilities reporting last year. And with that, there's also a decrease in the number of doses that it's counting that's been administered. And so by age group, we have the yellow line at the bottom, the 6 months to 17 years. The orange line in the middle is 18 years and over, and the gray line is all ages. And you can see the number of doses, total number of doses has gone down over time. Next. So that being said, this is the overall vaccination rates over the last 6 flu seasons. And you can see there's not really been that much of a change, certainly not a trend change here. We bounce around for all ages, the darker line in the middle, ranging from around 37% down to about 35%. Slightly higher for 6 months to 17 years old, and a little bit lower for 18 and all age groups. And so this has been pretty steady despite the change in vaccine reporting that I showed on the previous slide in this system. And hopefully we can do better. I'd like to see us get up to 50% or higher. I've talked before on other webinars about if we could reach 50% or higher, we might be able to have an impact on whether there's a spread of flu in our community, if we can get to that rate. And that's just a ballpark to aim at. Obviously, we'd love to get higher, like 70 or 80% vaccinated. Next slide. So all of the previous slides I showed come from the influenza-like illness awareness system. This slide doesn't. This comes from our National Immunization Reporting System, or NIRS. And it's the system where our immunization coordinators run reports in RPMS, and then they log into this system and they can put in the data from those reports. And what I've looked at here is the data that was inputted during the last quarter, which ended March 31st. And that's where we collect our healthcare provider influenza vaccination coverage. The exception on this one is for Navajo. We didn't have their report, their end of the season report in March, but we had their mid-season report, which was also really good. So I included that for Navajo for the light blue line. And what I'm comparing is last year versus this year. And if you remember, we went to a mandatory influenza vaccination policy for IHS a few years ago. And since then, we've had an increased percentage of our healthcare providers being vaccinated for influenza. And you can see by each area, there's been some increase in most areas between this year and last year. All of our areas are close to or above 80%, and many of our areas are actually close to our goal, which is 90%, with Navajo and Oklahoma, Great Plains, Billings, Bemidji, Albuquerque, having exceeded that 90% mark either this year or last year. So we're doing really well overall, I think, in vaccinating our healthcare providers. Again, this is an RPMS dependent report. There are a few sites that use other electronic health record systems that can mimic this report, or they can run similar data and upload it into this system. But for the most part, these are facilities using RPMS. And also you can see that the number of facilities reporting went down from last year to this year from 110 to 85, and that is about 6,000 fewer personnel whose vaccines are being reported on in this data. Next slide. So I'm just going to close with a couple of best practice ideas that have come. I gleaned these from previous webinars, that either the immunization coordinator webinars or other webinars that we've hosted over the years, where our on-the-ground frontline immunization coordinators have shared with us some of the things that they've done that have made a difference in their flu vaccination efforts. First and foremost is to plan ahead. And usually around this time, we do begin having a webinar that talks about flu planning for the upcoming season, and how important that is to look at your system, get things in place, plan ahead for the kinds of things that you might be doing to shore up or increase your flu vaccination coverage. It's really important to get buy-in from your internal stakeholders, so making sure that the medical staff, that the frontline staff, the MAs and the nurses are all on board with promoting the use of flu vaccine and understanding why flu vaccination is so important. Also outreach to the external stakeholders in your community. So if you are in a community where maybe some of the health programs are run by tribes and other programs are run by IHS, reaching out to those tribal programs and making sure they're on board with the efforts that you want to engage in to promote flu vaccination. A lot of clinics will have a nurse-only immunization clinic set up, and they might do that 1 or 2 times a week in normal times, and then during flu vaccination season, they might host that nurse-only immunization clinic every day. They also turn to pharmacists as immunizers, and they also work on increasing flu vaccination in their emergency room and also among their inpatients. So putting up reminders so that when patients are getting discharged, if they haven't had a flu vaccine during flu season, they'll get they'll at least be offered the flu vaccine prior to discharge, along with other vaccines that they might be missing. Other best practices include utilizing standing orders. I think most of our sites are doing this, but that allows nurses to be able to vaccinate without having to go through extra steps to get an order from a provider for that vaccine. And by reviewing someone's immunizations at every visit, you can avoid missed opportunities by offering the services they came in for, whether it's a cut that might need sutures, or a cough or a minor illness that they need addressed, or if it's chronic well care. We make sure that we look at the immunizations that they've received and make sure that we're offering everything that they should be getting at that visit. And then we look for opportunities to vaccinate outside of our routine clinic visits. So in normal flu seasons, we go out to schools, we go out to community centers, we go out to elder programs. We plan parking lot drive-throughs where folks don't have to get out of their car. They can just drive through and get a vaccine. And that always seems like such a novel thing. But in the age of COVID, we're providing all kinds of care out in the parking lot these days. And so I'm hoping that it'll actually be much easier for us to do more flu vaccines in the parking lot, because we've been doing a lot of care in the parking lot the last 3 or 4 months. And also it's going to be important because a lot of these community sites that we normally vaccinate at are not open, they're closed, because we're not meeting there. We're not having those programs in person, face-to-face, because of COVID. So we're going to have to really look carefully at all the places we normally vaccinate and see what we need to do differently this year. I can't say enough about also advertising in your local media, whether it's PSA spots on your local radio station, or having someone from the clinic get on the radio and talk about flu, and getting good information about what's going on with the flu vaccine, what changes are being made in your clinic for how you're providing flu vaccines this year. All of that will really be helpful. Most of our clinics have a Facebook page, and so this is a place where you can advertise those changes that you might be making, and when you start getting flu vaccine in, that you're ready to start giving it to the community, you can advertise that using your Facebook or your websites, and then coordinating those messages with your tribal programs as well to really get the word out. And then, like I mentioned before, protecting elders by vaccinating children, I think, is a really important step that we can take. There's conflicting evidence about how useful that is. I don't think we've really done that on a large enough scale to be able to really measure the utility of it. But we know that for some diseases that does make sense. And certainly in the time of COVID, we were all talking about how we need to protect those who are most at risk for complications of disease. And that includes our elders in our community. So anything we can do to protect them, and one of those things we can do is to step up our game in vaccinating children, in addition to vaccinating elders and those that care for elders in our community, and all those that have high-risk conditions. So that's really my last point, is looking at now how we need to step up our game on planning for flu vaccine this year. And we're going to learn more about some of the considerations that CDC has looked at to help us and guide us in making those plans. So thank you very much.
Thank you so much, Dr. Weiser, both for the big picture overview as well as some very practical reminders towards the end of your presentation. A question came through the Q&A from Dr. Laura Hammett, and I think it might be well directed to you. Dr. Hammett writes, thanks for the great presentation. Do we know what is happening with IHS routine immunization coverage in the first half of 2020?
We don't know yet. So I have looked at the first quarter and second data. Second quarter was reported March 31st, so about 2 weeks after the national declaration. And we just saw a slight decrease, maybe a 4% overall, percentage point overall decrease in childhood vaccinations, 2-year-olds being up to date. And even less, I think it was 2% for measles containing vaccine. So I'm really anxious for our reporting. The third quarter just closed on June 30th. And so we usually give about 2 to 3 weeks for folks to get those reports into the system before we start going in and looking at it. But probably by the end of July, we'll close off reporting and we will have the information that you're asking for. I'm afraid that it probably will be low, as we've seen from CDC reporting for VAERS and the other system that they reported on in their MMWR a few weeks ago. There was a decrease in vaccines ordered and vaccines administered. So we'll see just how that has impacted us, and then we will be addressing that. We tried to get the word out preemptively to try and address that before those the quarter close and see if it can be taken care of. We'll just see how it is.
Thank you for that. And just for everyone, Dr. Hammett also shared some resources regarding maternal flu vaccination developed based on formative work with several tribal communities. And there's a link to that, which we will leave in the Q&A session. Thanks again, Dr. Weiser. And without any delay, I want to turn things right over to Lieutenant Commander Tara Jatloui, who is a medical officer with the U.S. Public Health Service and is the adult immunization lead in the Immunization Services Division at CDC. Dr. Jatloui currently serves as the lead for the Influenza Planning Response Team in the CDC COVID-19 response. She is co-lead for the National Adult and Influenza Immunization Summit Access and Provider Work Group and serves on the work group for the ACIP Combined Immunization Schedule. Dr. Jatloui completed residency and fellowship training in the Department of Gynecology and Obstetrics and obtained her MPH in epidemiology at Emory University. She remains clinically active at Grady Memorial in Atlanta and is adjunct faculty at Emory University School of Medicine. Dr. Jatloui, thanks so much for your time. I'm sure you're very busy, and we look forward to your presentation. Thank you.
Well, thanks so much for having me. I'm going to pull up my slides here, so just give me a minute. Not sure if that didn't work how I wanted it to. There we go. Are you able to see my slides? Great. Perfect. Okay. Well, for the next 20 minutes or so, I'll be reviewing data from the last influenza season on a national scale and sharing information that was presented at the most recent ACIP meeting at the end of June. And most importantly, I'll be reviewing new CDC interim guidance for immunization services during the COVID-19 pandemic. So first, review data from last influenza season. As was mentioned before, the influenza season presented here by week of the year, there was an initial wave of flu activity that was predominantly influenza B, followed by a later wave of influenza A, H1N1. And as of June 13th, 2020, there were 185 deaths of children associated with laboratory confirmed influenza reported to CDC. CDC estimates that the 2019-2020 season resulted in many millions of illnesses and medical visits, hundreds of thousands of hospitalizations, and tens of thousands of deaths. Moving on to surveillance for influenza-like illness, or ILI. These are data from the ILI Net, a network of providers who report weekly the percent of outpatient visits for ILI. Several seasons are represented in this graph. The most recent is the red line with triangles. There was relatively high ILI activity from late December through February with 2 peaks. Then there was a 3rd peak. Because this is ILI, which uses a symptom-based definition, other pathogens besides influenza could be involved. By the time of this 3rd peak, we know from other surveillance indicators that influenza was still circulating, but activity had already begun to fall pretty dramatically. We know that SARS-CoV-2 activity, the virus that causes COVID-19, was increasing at that time, and so we assume that the 3rd peak was due in large part to COVID-19 rather than influenza. So next, if we look at influenza-associated hospitalizations, this comes from FluSurvNet. This chart shows cumulative hospitalization rates per 100,000 for lab-confirmed influenza by calendar week. Each colored line represents a different season, with the most recent in red. And this line shows hospitalizations occurring between October 1st, 2019 and April 30th, 2020. For this period, the cumulative hospitalization rate was approximately 69 per 100,000. That's less than the 2017 to 2018 season, represented by the uppermost curve, but was higher than the recent non-pandemic season shown. Next, we have influenza-associated mortality data. The data on the left from the National Center for Health Statistics, or NCHS, come from death certificate diagnoses and are reported as the percent of deaths due to pneumonia and influenza-coded diagnoses. So this is diagnostic code data and not laboratory confirmed influenza. Again, calendar week is on the x-axis. Several seasons are in the figure, with the most recent on the far right. For the earlier part of the season, values are relatively low, but then we have a large peak in pneumonia and influenza deaths in the latter part of the season. This is thought to be largely due to COVID-19. The figure on the right shows pediatric mortality associated with laboratory confirmed influenza, which has been reportable since 2004. As of the most recent reporting week, 185 pediatric deaths were reported, as I noted before, and this is fairly close to the 188 reported for 2017 to 2018. Among these deaths, 71 were associated with influenza A, 114 to influenza B viruses. In general, in these data, among those children who are eligible for vaccination and for whom vaccination information is available, the majority are not vaccinated. Next, I'm going to review some additional information and proposed recommendations presented at the ACIP meeting at the end of June. The main influenza recommendation for vaccination remains unchanged. That annual influenza vaccination is recommended for all persons aged 6 months and older who do not have contraindications. There are 2 primary updates to the recommendations. First, the U.S. influenza vaccine viral composition has been updated for 2020-2021. Second, inclusion of 2 recently licensed vaccines, Fluzone high-dose quadrivalent and Fluad quadrivalent. So first, with regard to vaccine composition, for 2020 to 2021, there have been updates to the influenza A H1N1 PDM09, influenza A H3N2, and influenza B Victoria components. These are the components in red. The B Yamagata component is the same as last season. Egg-based influenza vaccines will contain hemagglutinin derived from an A Guangdong Mayonan SWL1536 2019 or H1N1 PDM09-like virus, and A Hong Kong 2671 2019 H3N2 virus. B, Washington 02 2019 Victoria lineage-like virus, and for quadrivalent vaccines, a B, Phuket 3073 2013 Yamagata lineage-like virus. Non-egg-based influenza vaccines will contain hemagglutinin derived from the following lineages that are listed below. The second primary update is that there are 2 new influenza vaccines that were licensed after the publication of the 2019-2020 statement, and which are expected to be available for the first time during 2020-2021 season. First, in November 2019, the FDA licensed Fluzone high-dose quadrivalent from Sanofi Pasteur for ages 65 years and older. And like the previous trivalent high-dose vaccine, this vaccine contains 60 micrograms of hemagglutinin per vaccine, which is more than the 15 micrograms per virus in other inactivated vaccines in a 0.7 milliliter dose. That dose volume is slightly higher than that for all other injectable vaccines, including the previous trivalent version of Fluzone high dose, which was 0.5 milliliters. And this vaccine will replace the previous trivalent Fluzone high dose for this upcoming season. Pre-licensure data were presented to the ACIP last fall in October of 2019. In February 2020, the FDA licensed Fluad quadrivalent for persons 65 years and older, and this contains MF59 adjuvant, similarly to the previously licensed trivalent formulation of Fluad. And these data were presented to the ACIP in February of 2020. There are several other changes and clarifications. First, in the contraindications and precautions table, which is table 2 of the recommendations, the text of the header, which previously read, I'm sorry about that, contraindications and conditions for which use is not recommended, that's been changed to be clarified to just contraindications. And the original header reflected the fact that for one of the vaccines, LAIV4, there are some labeled contraindications that are listed in the package insert, and others which are not labeled contraindications, but instead are situations in which ACIP recommends that it not be used. However, following discussion of this issue in the context of the adult and pediatric schedules at the fall October ACIP meeting and ensuing work group discussion, the consensus was that it was more clear to just call this contraindications. Now, I do have some slides that that include more information on the data that went into those recommendations, but in the interest of time, I'm going to skip those, but you'll have those slides available for those interested in more details of those methods and results. So the last update concerns use of antivirals. The statement has for several years previously indicated that use of influenza antivirals from 48 hours before to 2 weeks after administration of LAIV4 may interfere with the effectiveness of vaccine since it's a live virus that must replicate in the nasopharynx. This time interval is noted in the package insert for that vaccine. However, the newer antivirals, Peramivir and Baloxavir, have longer half-lives than also Tamivir and Zanamivir. And unfortunately, insufficient data are available considering the use of live attenuated influenza vaccine in the setting of these new influenza antivirals. So we don't know whether to what extent interference with the vaccine might occur, but it seems biologically plausible that interference could occur. In discussions with the working group, the following was proposed that you see here in sort of the table. Based on the half-lives and assuming a minimum of 5 half-lives after the last dose being needed for adequate washout of the antiviral medication, language has been added indicated it's prudent to assume some interference is possible if antivirals are administered within these time intervals. Finally, the language concerning persons with a history of severe allergic reaction to egg is updated to reflect that there's availability of 2 egg-free vaccines. So for these individuals, if a vaccine other than the cell culture-based inactivated vaccine and the recombinant influenza vaccine is used, that vaccine should be administered in an inpatient or outpatient medical setting, supervised by a healthcare provider able to recognize and manage severe allergic reactions. So here's a summary of those changes. And again, I'll move quickly because I know we don't have a lot of time. And I'm going to move on to the interim guidance for immunization services during the COVID-19 pandemic. And what's been mentioned before, it's extremely important to assess and ensure that patients are getting their routine vaccinations. Here's some data that was published in an MMWR that showed that the Vaccines for Children program had decreases when you compare 2019 to 2020, looking at across those federally purchased vaccines for eligible children in the United States. So in order to assess the impact of these reductions, CDC looked at weekly VFC vaccine orders for all childhood vaccines other than flu in 2020, and those are shown in the orange bars, and then 2019 is in the blue bars. And the slide shows a dramatic reduction in vaccine orders beginning in mid-March and extending into early May. And we've seen some recovery in that, but you can see the impact that shutting down has had on routine childhood vaccination. The guidance that was released really highlights that routine vaccination prevents illnesses that lead to unnecessary medical visits and hospitalizations, further straining the healthcare system. And influenza vaccination will be more important than ever this season to reduce the impact of respiratory illnesses and the resulting burdens on the healthcare system while SARS-CoV-2 is circulating. To address the drop in rates, we recommend providers assess vaccination status of all patients to avoid missed opportunities and ensure timely vaccination catch-up for any that have been missed in this time. Vaccination should be administered when they're either due or overdue according to the recommended schedule. In the guidance, we make the following statement for these different patient populations. For children and adolescents, reschedule missed well-child visits and or recommended vaccinations, prioritizing newborns, infants, and children up to 24 months, young children, and extending through adolescence. For pregnant women, if vaccination has been delayed, administer the vaccine during the next in-person appointment. And for adults, continue to ensure patients are receiving recommended vaccines, and older adults and those with underlying medical conditions are particularly at increased risk if vaccination is deferred. Because we expect that SARS-CoV-2 to continue to circulate in the fall, influenza vaccination will be an important strategy to decrease stress on our healthcare system and our communities by decreasing doctor visits and hospitalizations, as well as decreasing the number of people who will need diagnostic testing. Given the risk groups that have been identified for COVID-19, influenza vaccination will be particularly important for staff and residents of long-term care facilities, adults with underlying health conditions, African Americans, Hispanics, American Indians, and Alaska Natives, and adults who are part of critical infrastructure, which does include healthcare personnel as well. For the guidance, we recommend providers use every opportunity to administer influenza vaccines to all eligible persons, including those that were listed in the previous slide, bulleted out here. Catch-up vaccination strategies are highlighted in the guidance, include reminder recall systems, forecasting through electronic medical records or IIS, and the use of standing orders that was mentioned before. While we recommend patients receive vaccines in their medical home, vaccination at locations outside the medical home may help increase access to vaccines in some populations or situations, particularly when the patient does not have a primary care provider or when care in the medical home is not available or feasible. Therefore, it's critical all vaccines are documented for accurate and timely information on the patient vaccination status, regardless of where they receive it. So in the next few slides, I'll review some more detailed guidance for safety considerations while administering vaccines during the pandemic. One of the most critical pieces is that routine vaccination should be deferred for persons with suspected or confirmed COVID-19, regardless of whether they have symptoms or if they're asymptomatic, until criteria have been met for them to discontinue isolation. And those are linked in the guidance because the criteria have changed over time. While mild illness is not a contraindication to vaccination, vaccination visits for these individuals should be postponed to avoid exposing healthcare personnel and other patients to the virus. And when scheduling or confirming appointments, patients should be instructed or screened for any symptoms that they may be having. The potential for asymptomatic transmission of the virus underscores the importance of applying infection prevention practices to encounters with all patients, including physical distancing, respiratory and hand hygiene, surface decontamination, and source control while in a healthcare facility. And specific recommendations include screening patients for symptoms before and during a visit, physical distance throughout the visit where possible, limit and monitor facility points of entry, install barriers to limit physical contact with patients at triage. Respiratory hygiene in further detail includes face masks for staff, face coverings for patients 2 years of age and older if tolerated, cough etiquette, hand hygiene for patients. And our guidance also links to other guidance materials for COVID that may be of interest to this audience. As far as personal protection equipment or PPE, we recommend face masks for all healthcare personnel. Eye protection is recommended in areas with moderate or substantial community transmission. For those with minimal or no transmission, eye protection is considered optional. And while gloves may be used for vaccination following ACIP recommendation, these may be used for IM or sub-Q vaccinations and should be replaced between patients and hand hygiene performed. Because of COVID, gloves are recommended for intranasal or oral vaccines. Physical distancing is critical, and in order to accomplish that in normally busy clinics or clinical settings, here are some recommendations and suggestions that have been provided, such as separating sick from well patients, using scheduling or different locations or different areas of a facility, as well as ensuring physical distancing throughout a visit and considerations for reducing crowding in a waiting room when possible. It's also important when communicating the importance of vaccination that there are, to communicate that there are safety protocols and procedures in place to help reassure and inform patients of what to expect in order to receive immunization services safely. We have heard from for some formative research that's being done that patients are scared to come into an office. So having communication that sort of reassures them of what's being done can be helpful for them. I mentioned it may not be feasible for all patients to receive vaccines in their medical home. So I'll just be going through, and I know I just have a few minutes left, some additional recommendations for alternative vaccination sites. These could include those that are listed here. And some of the basic guidance that's included in this interim guidance document that's at the link at the bottom include those bulleted out, which really, is paying attention to physical distancing that's happening in that space. Finally, I'd just like to highlight some more resources available and additional updates for the upcoming flu season. This is where our guidance lived, and I shared this link earlier. Just to make you aware, we should be posting probably in the next week some additional guidance on temporary or off-site clinic or immunization clinics. And those will include guidance for drive-through clinics or considerations for pre-planning during a clinic activity and post-activity information, which may be helpful when you're thinking about providing immunization during flu and in the future for COVID vaccine. So I think I'm going to stop there. I can take a look at the chats to see if we have any questions in the next final minutes, because the rest of my slides are resources and links for more information for COVID documents that may be of use, and flu information for surveillance and for guidance that we have available. Thank you.
Thank you very much, Dr. Jat-Louis. That's an amazing amount of information in a short space of time. Thank you for really bringing us up to speed. I think we all have just about as much information as any clinician or clinical leader does regarding the updates for flu vaccine. And what I'm taking away from that, one of the key points is that we're going to have to find novel ways to get flu vaccines to people, because most of our sites have reduced services. They're slowly being reintroduced, but given the waves we're seeing, I think it's unlikely that many, if not most, sites are going to see 100% service availability as compared to a year ago. So I think that's something for everybody to be thinking about. And as an emergency medicine person, even though it's very hard on our flow, I think we need to consider things like, how are we going to deploy this in the emergency departments, if at all possible. So thank you for really bringing it all together with the idea of keeping folks safe, keeping folks feeling safe when they come in for their vaccinations, because it's going to be, as you said, one of the most important years in our careers for this vaccine to roll out. We are just over the hour. Unfortunately, we've already, one of our speakers, Johnny Erlew, had to step away because he's hosting an additional session right now. So let me just close by saying thank you to Dr. Tom Weiser, Dr. Tara Jat-Louis for your time. We understand how busy you are in each of your posts and appreciate you bringing us up to speed on the flu picture and then the vaccination outlook for this year, a critically important message. Thanks to IHS headquarters for the support of these sessions, to the ECHO team for keeping us running smoothly every week, and to all the participants who took time out of their schedule to observe and participate in the presentation today. Thank you all very much. Wish all yourselves and your teams well, and hope you all are staying safe. Thanks, everyone.